Chapter 56, Acute Intracranial Problems. That's going to consist of intracranial pressure, head injuries, brain tumors, cranial surgery, and other inflammatory conditions of the brain. This lecture is going to be broken up into two lectures. This first lecture here is going to be talking about intracranial pressure as well as head injuries. Lecture 2 will talk about the remaining. So intracranial pressure, I'm going to be referring to that as ICP throughout the lecture. Basically, that's just a pressure or a force measured within the brain compartment. The skull is composed of three essential components, which is the brain tissue, the blood, and the CSF, the cerebrospinal fluid. So in normal conditions, what happens is these three remain in balance with each other, and that balance maintains a normal ICP pressure. If you look at this diagram over to the right, this will show you conditions that are affected by the specific components of the skull. So primary injury is in that it's primary, is that it occurs at the initial insult of injury. So whether it's a trauma or any kind of injury, basically it would be considered a primary injury at the initial insult. Secondary injury follows the primary injury in that it occurs later. It is a complication that occurs after the primary injury, whether it be several hours or whether it be several days after the primary injury. Know that these factors influence ICP, arterial pressure, venous pressure. You can read through these, but know that these do affect the ICP. So Monroe-Kelly doctrine is that basically those three components of the brain need to remain in balance. So if one of these components increases, another component must decrease in order to maintain that autoregulatory system, to maintain that pressure, that ICP pressure. And if one of the other areas are unable to compensate for the changes, then ICP will increase. Normal ICP is 5 to 15 millimeters of mercury. Know that. So if a person has a sustained pressure greater than 20 millimeters of mercury, then that's considered abnormal and it must be treated. If not, there'll be complications. And ICP is measured through a pressure transducer system, similar to an arterial line, if you've seen something like that in practice. And it is leveled, and so when it's leveled, it gives the nurse a number on the monitor to know what the ICP is. Know that the catheter for ICP measurements can be placed in different areas, and the areas are listed here on this slide. This diagram over to the right, or picture, it does show clinical manifestations of increased intracranial pressure. That's very important to know. A lot of your nursing NCLEX questions regarding ICP will consist of knowing the normal pressure and knowing the clinical manifestations as far as what you should be monitoring for during your frequent neuro assessment. Cerebral blood flow is the amount of blood that passes through the brain tissue. It's critical because it does provide the brain with oxygen and glucose in order to function properly. Basically, it's the blood that's being supplied to the brain. Cerebral blood flow does have a system called autoregulation, and the autoregulation system adjusts the diameter of the blood vessels in the brain in order to maintain a constant flow during changes that occur with arterial blood pressure. It ensures that there's consistent blood flow to provide those metabolic needs, the oxygen and the glucose to the brain. And it only works if the person has an adequate systolic, diastolic blood pressure to give a good map. So if their mean arterial pressure is 70 to 150, then this autoregulation system is going to occur. If their mean arterial pressure is in the 40s, then this autoregulation system will not occur. To determine the pressure, cerebral perfusion pressure, which is the pressure needed to ensure that that blood flow gets to the brain, there's a formula that you use to calculate that. And if you'll see here, CPP, which is cerebral perfusion pressure, equals the MAP minus the ICP. So you may get a test question that gives you a systolic and a diastolic blood pressure as well as an ICP, and you have to calculate what the cerebral perfusion pressure is. So look over this formula be familiar with doing this formula. If you have questions doing it or you're having difficulties getting the answers, please reach out to me. This example here gives you an answer of 85 millimeters of mercury, and it's asking, is this a normal range? Yes, it is. Normal is 60 to 100. If you look at example 2, work through that, the answer that you should get for that is 102. And it's asking us, this in normal range? No, it's a little bit above normal. Remember, normal is 60 to 100. So 102, an elevated CPP, what happens? It's barely elevated, so in this patient, clinically, there may not be an effect at all. If a CPP gets too high, let's just throw out a ballpark number and say it's 150. Okay, you've got a pressure, which I've never seen a pressure that high, but if you see a CPP of 150, then at that time what's going to happen is this patient's going to have cerebral edema, and cerebral edema may lead to brain herniation, which may lead to brain death. So just know too high of a pressure that puts them at risk for cerebral edema. In some cases, your provider may want this patient to have a little bit higher than normal CPP, like they may want a pressure of like 110. And you may see that in instances in patients that have had like an acute stroke where the CPP, it doesn't tell you all of the areas of the brain. So there may be areas that have local swelling or compression, and so the provider or physician is wanting to have an increased CPP in order to make sure that they're getting adequate blood flow to the brain despite those issues. If you look at example 2 and work through that one, the answer that you should get for that one is 53. So is that in normal range? No, it's not. It's low. So what you need to know about that is that if you have somebody with a lower pressure, they may not be getting those metabolic needs to the brain. They may not be oxygenating to the brain or getting the glucose that they need for those neurons to survive in the brain. If you have somebody that has a pressure that's lower than 50, then that is associated with ischemia and neuron death. If you have somebody that's less than 30, that typically is incompatible with life. So that's why this is an important pressure, and it's an important pressure to know. So be familiar with that for sure. This slide here is talking about pressure and volume changes and how it plays into compliance, which is the expandability of the brain. This is on page 1315 and 1316 if you want to read more about it after I discuss this slide. Basically, if you have somebody that's got a high compliance, their auto-regulation system is going to work good. So they will have an increase in their volume within the brain or blood or CSF, but as you can see, it doesn't really affect their ICP. Their ICP is not going up. So their auto-regulation system's in good effect at this point. They're doing pretty good. Now, with low compliance, as you see here, they're having increases in their volume, not even by a lot, and you'll see their ICP is going up. Just by 1 milliliter volume change, their ICP has shot from, I guess I'd say that's about a 13 here, all the way up to about a 25. So it's important to know that if your ICP continues to rise and you can't get that level down, then it can turn lethal for that patient. And what will happen is they'll have brain herniation, which will lead to brain death. So it's important to try to keep that auto-regulation system in check by helping to make sure that their blood gases stay in control and their blood pressure and heart rate stays under control, and you're really paying attention to your assessment findings, both vital sign-wise and neuro assessment wise. If increased ICP occurs, you'll see Cushing's triad. This typically is an NCLEX question. It is considered a neurologic emergency. Basically, it's where they don't have that auto-regulation system, and now you're seeing it in your vital signs. Your blood pressure is going to be elevated, your heart rate is going to be decreased, and your respirations are going to be decreased. Notice that that is complete opposite of shock. In shock, like we learned earlier, the blood pressure is going to be low and their heart rate is going to go up and they're going to be tachypnic. So no, I would put that in my brain to learn that for NCLEX studying as well as for this exam. So herniation is basically where the brain tissue is forced out into another compartment. due to the increased pressure, and it can lead to brainstem death. These factors affect cerebral blood flow, and that would be CO2, O2, and hydrogen ion concentration, and that's where your blood gases come into play, and they're important to monitor. If you've got somebody that's got elevated hydrogen ions, then they're going to be acidotic and they're going to vasodilate. So when they vasodilate, their systolic and diastolic pressures are going to be low, which means your MAP's going to be low, which means your cerebral perfusion pressure will be low. And the lower your CPP is, the worse outcome that you have. So be familiar with how the CO2, O2, and hydrogen ions play on the cerebral blood flow system. Like I said earlier, increased ICP can be life-threatening. Any increase in one of the compartments can lead to increased ICP. This diagram here just shows you brain herniation. So if you look here on A, this is a normal picture of the skull and the brain. If you look here on the right, you see there's an intracranial tumor. This tumor is pressing on brain structures, and what will happen is that shift will actually cause increased ICP, and what will continue to happen from that point forward is the increased ICP will cause this herniation where the actual brain tissue will herniate into another compartment. Know that if there's compression of the brain stem, respiratory arrest will occur. So cerebral edema, that's an increase in extravascular fluid in the brain. If you look on page 1317, you'll see table 56.2. These are some common causes of cerebral edema: hematoma, brain tumor, abscess, meningitis, hemorrhage. You can kind of read through those. I don't want you to memorize that. I just want you to be familiar that there's multiple causes that can cause cerebral edema, and that there's three types. There's vasogenic, cytotoxic, and interstitial. You can have a patient that can have two different types at the same time. They can have vasogenic and cytotoxic, or one of the others. So vasogenic cerebral edema, this is the most common type. If you think of third spacing in your vascular system, this is very similar, but it's just in the brain. So what happens is the fluid from the intravascular system, the cerebral vascular system, starts leaking outward into the extravascular system by osmosis. And typical symptoms would start like with a headache and change in level of consciousness, and it can then progress to coma, and it can be very quick. So make sure to check your neuro assessments. Cytotoxic cerebral edema, this is actual disruption of the cell membrane integrity, and it can be due to trauma or lesions or tumors. And what happens is the fluid shifts from the extracellular, from outside the cell, and it moves into the cell. Interstitial cerebral edema is due to hydrocephalus. It's an excessive amount of cerebral spinal fluid, and whether it's from too much production of the CSF, or it's where the CSF is unable to drain. Maybe there's a tumor obstructing the outflow right there, and so that needs to be treated. Typically, be sure to know your clinical manifestations of increased ICP or ICP. Know that a change in level of consciousness is the most sensitive and reliable indicator of neurologic status. And you may have somebody that you went in and did an AM assessment and they were awake or oriented, and an hour later you go in and they're obtunded, or an hour later you go in and they're just having some mild delusions or hallucinations rather, or just seem a little off as far as confusion. So just know it could be very dramatic, or it could be just small subtle changes throughout the shift. Know your changes in vital sign. In addition to Cushing's triad, the patient may have a change in temperature due to increased ICP. They may have ocular signs, so be sure to check your cranial nerves and look at your face as far as assessment. They can have a drooping of the eyelid. Ipsilateral always means on the same side. Contralateral means on the opposite side. These are clinical manifestations as far as musculoskeletal system. If you look here at A, this is decorticate posturing. This is where everything is flexed inward. Everything's moving in towards the core. If you look at B, that's decerebrate posturing, and that's where all the extremities are rigid and they're extended outward. see here, this is basically where they have decorticate response on one side of the body and a decerebrate response on the left side of the body. This is opposite side of the mass, so it's going to be contralateral. So if they have a mass on the left side, then they're going to have this hemiparesis or plegia on the right side. And ophthalmic posturing, D, you don't see this very often, especially I've never seen this in the infant or small children population where you would see this. Basically, it's where they're actually coming up off of the bed and their back is becoming arched and their neck is hyperextended back, and it's due to spasms. So just be familiar with those and know those. Headache, often continuous, can be nighttime or it can be in the morning. Headache can be worse in the morning. They may have nausea, they may have vomiting. Vomiting, if they have, it's typically projectile. So diagnostic studies, H&P, neuroassessments, vital signs, ICP measurements, CPP measurements. They may do some skull or spinal x-rays, especially if they see that there may have been a trauma, CT scan, MRI, PET scan, especially if they're suspicious for a cancerous lesion, EEGs to determine seizure activity. They may have seizures secondary to increased ICP, lab studies, as well as this Lickox catheter. You don't see this too often. You may see it in a neuro ICU setting. I don't really expect you to be detailed as far as knowing this. Just know that it is a catheter used to mainly determine brain tissue oxygenation. It's kind of like a pulse ox within the brain, but it also can measure ICP as well. With increased ICP, diagnosis is not by lumbar puncture. Lumbar puncture in these patients that have increased ICP actually can hurt the patient because cerebral herniation can occur due to that sudden release of pressure in the skull. Indications for ICP monitoring would be if they have a GCS scale of less than or equal to 8 and they have an abnormal CT or an MRI. These are the areas where ICP catheter can be placed for monitoring. Ventricular is the gold standard, but just know that these other areas can be placed as well. So if the catheter is placed in the ventricle of the brain, it is then connected to an external transducer, and that measures the pressure within that ventricle. It also will facilitate removal of CSF fluid, where you can sample that fluid or drain off fluid if there's too much. And it also allows for drug administration into that ventricle. So the ventriculostomy is the best location if that possibly can be used for your ICP. So here's where she's leveling the transducer. If you remember from arterial lines, they have to be leveled. Just like with that, the ICP transducer needs to be leveled. And if you just point to the tragus of the ear and guide it, that's where you're looking for your stopcock to be leveled, this right here. That's what you're looking for. So the biggest thing to know is that if you're doing any kind of patient care or anything where you're adjusting the bed, x-ray comes in and they adjust the bed to take an x-ray and then they leave and they don't put the bed back down, well, you got to go in there and adjust this to the tragus of the ear, which would, test question wise, would be the foramen and Monroe. So this is just basically another picture that kind of tells you the ICP catheters take down, and it goes to the transducer, and then the catheter or the connector from the transducer goes to the monitor, and that gives you a waveform where the ICP is represented. And the waveform, a strip of the waveform should be put into the patient's chart once a shift. So measuring ICP, you want to make sure to prevent and monitor for any kind of infection. So if you've got somebody that has a CSF leak or they've got a systemic infection, let's say they've got MRSA in the blood, they're a higher risk of getting an infection in the CSF. If they've had an ICP monitor for an extended amount of time, then that predisposes them to infection as well. Know that inaccurate readings, you've got somebody that had your whole shift to ICP measurement between 10 and 13, and then all of a sudden you see that their reading says it's like 50 and the patient looks fine, the neuro assessment is fine. Look at your patient, look at your vital signs. If it doesn't match up, that there's not any changes, okay, well, check your system. Is there air or bubbles in the tubing? Is your transducer where it needs to be? Is there a leak around the actual catheter? Just look at your patient and look at your system and figure out what it is. And if you can't figure it out, then grab another set of eyes. CSF drainage, that can be done to control ICP if need be, and that's going to be per your provider orders. They may have it set to where there's intermittent drainage based upon what the ICP is, or they may have continuous drainage orders. But it's very, very important that you monitor that volume that's being drained. You don't want to have rapid drainage because you'll have ventricular collapse. So that leak ox monitor that I was telling you about, and this just checks for brain oxygenation, and it also can measure ICP as well as temperature. Another way that they can check for cerebral oxygenation is by doing a jugular venous bulb catheter that is put into the internal jugular vein. And those are things that are done within an ICU setting. Interprofessional care, nursing care goals, we want to identify and treat the cause if possible. And that's not nursing so much, that's in collaboration with the provider. And you're going to be working with the neurosurgery team in this case. So surgery, if possible, craniectomy, you want to make sure that we're maintaining that oxygenation to the brain. So we're seeing that we've got good cerebral perfusion pressure, 60 to 100. We're making sure that our gases look good, making sure that PO2 looks good. And if they need to be intubated and ventilated because their gases aren't doing good or their SATs aren't looking good, well, that's when you call the provider. These are the drugs that can be used. Mannitol can be used to decrease the ICP. Hypertonic saline solution. Corticosteroids can help to reduce cerebral edema. Anti-seizure medications, which may actually be used prophylactically, not just for treating active seizures. Antipyretics to control the fever. Sedatives to control agitation, analgesics to control pain, and barbiturates can be used in high doses to treat increased ICP that's been refractory to other treatments. You don't see that too often, but it can be done. Nutritional therapy, these patients need to have a good nutritional status. So they're in a hypermetabolic state, just like with shock. Nutrition needs to be discussed early on. Assessment, you're going to attain your subjective data, your history, objective, look at what's your level of consciousness. You're going to assess your Glasgow Coma Scale, which is the gold standard assessment tool for checking your LOC. Make sure you're very familiar with this scale. You can look at it in the textbook, page 1323, table 56.5. So be familiar with your assessment of your eyes. Know your cranial nerves. Familiarize yourself with this doll's eye reflex and the caloric stimulation in your book. Planning the goal. Make sure that they've got an airway. You're trying to keep your ICP within normal limits. Making sure that they're getting nutritional and fluid support, and that they're not becoming dehydrated. Look at your vital signs, look at your urine output. So we're going to maintain an airway when it comes to respiratory function. We're going to try and keep their head of the bed 30 degrees. That'll help to decrease the ICP. We're only going to suction when needed. We're not going to over-suction because that's going to stimulate and increase that ICP. And make sure that we're oxygenating before. If they're on the ventilator, then you're going to increase their oxygen temporarily to 100%, and then you're going to suction, and then you're going to go back down. You want to minimize any kind of abdominal distension, so if you've got somebody that needs NG tube or OG tube decompression, then try to get orders for that. Monitor your ABGs and work with your respiratory therapist to maintain your ventilator. If they're having a hard time with the ventilator due to agitation, then call your physician and get some orders for some sedatives or analgesics. And in some cases, patients may need paralytics just to make sure that they can maintain the ventilator settings and help to decrease the ICP and stop the sudden increases of pressure. Just know that if you have an ICU patient and they're on paralytics, okay, well, they're paralyzed, but they can still feel pain. So always make sure that you're getting analgesics on top of that. These are the analgesics used, pain and anxiety medications, and you can read through these. Fluid electrolyte balance, monitor and minimize any increases in ICP. So some of those, like I've talked about previously, suctioning. Other things would be coughing, sneezing, Valsalva maneuver, bearing down. So if they have issues with constipation, they need stool softeners and or laxatives. You want to make sure that you're not doing any kind of rapid movements. If you're going to turn them every 2 hours, try and turn them slowly. Avoid any extreme hip flexion because that increases your intra-abdominal pressure, which increases your ICP. Protect the patient from self-injury. If they have agitation and are having behavior changes, then make sure that you're providing a safe environment as well as for seizures. Try and keep the environment calm. If you walk into a neuro ICU, a lot of times everything's dark, it's kind of quiet, there's not a lot of stimulation, and that's for good reason. Expected outcomes, what we're evaluating for is that we're keeping those pressures within normal parameters and the patient doesn't experience any extreme increases with ICP, as well as complications related to immobility. If this is a patient that has been immobile due to whatever issue that they've had to increase their ICP, make sure we're doing gentle motions as far as with range of motion. So here's an NCLEX question. Okay, so we've got a client with a head injury that's got an arterial blood pressure of 92/50 and an ICP at 18. The nurse uses the assessments to calculate the CPP, the cerebral perfusion pressure. How should the nurse interpret the results? So in order to do this, I'm going to try and do this with you guys, we need to see what our map is first. So in order to do that, we need our diastolic, which is going to be 50. That's terrible writing, but just hang in there. And it's going to be a third. Ooh, this is awful. And then we're going to take the systolic minus the diastolic. So 92. This seems like it'd be simple, but it's not, you guys. Okay. So 92 minus 50, that's going to give us 42. And then we're going to take a third of 42, and that's going to give us 14. So we're going to do 50 plus 14. That's going to give us 64. So we're not done yet. That's our mean arterial pressure. So CPP equals your mean arterial pressure minus your ICP. So if we've got 64, we're going to subtract 64. Oh, that's awful. Minus 18. Okay, and that should give you 46, should be the answer to that. So now we can go on and answer it. A, CPP is so low that brain death is imminent. No, that would not be the case because remember, brain death is imminent is less than 30. CPP is low, so the blood pressure should be increased. That seems pretty good. CPP is high. Remember, your CPP is 60 to 100, so that would not be the case, and that rules out D as well. So your answer for this one would be B. Questions regarding this one, please definitely reach out to me. All right, moving on, we're going to move on to head injury or traumatic brain injury. Head injury is any injury to the skull, scalp, or the brain. Traumatic brain injury is the most serious form regarding a head injury. It does have a very high incidence in the U.S. Causes of head injury, you can see those listed below. Motor vehicle accidents is the most common. They're twice as common in males than in females, and head injuries do have a high potential for a poor outcome. Deaths occur at 3 points in time after the injury. It could be immediately, it could be within a couple hours, or it could be 3 weeks after, which is typically the scariest because it's so delayed. Types of head injuries, scalp lacerations is a type, and it's just like it says, this is laceration to the scalp. Just know that the scalp is very vascular, so they do have a lot of bleeding, so that's number one complication. And then if they have poor healing secondary to that, it could be infection. Skull fracture, another type of head injury. These are the type of skull fractures here. They're described in detail on your table 56.6. This is how, documentation-wise, this is how it will be described, whether it's a linear or depressed, a simple or a compound, or closed or open. Anyway, just familiarize yourself with the differences in these. Location in skull fracture does determine manifestations. If you look in your book at table 56.7, which is on page 1327, it'll tell you basically, like if somebody's got a fracture in the orbital, then they may have more eye-related injuries. I don't expect you to memorize each one of these, but just do read through it so you're kind of familiar with certain areas that are more prone to certain clinical manifestations. Complications, skull fractures, tissue damage, intracranial infections, or hematoma. So here's some manifestations. If you look at A, this is described as raccoon eyes, basically where they have that periorbital ecchymosis. They may have rhinorrhea, where they have CSF leakage from the nose. If you look at B, that's called battle sign. That's where they have this ecchymosis behind the ear here. And if you look at D here, this is a halo sign. So basically, if you've got somebody that's got rhinorrhea and you're testing to see if that's CSF, two ways of doing that. They can test for glucose with a special type of strip, and that'll tell them if it's CSF. If you don't have that way to test, then another thing that you can do is allow that liquid to drip onto like a 2x2 piece of gauze or a white towel, and then in a few minutes you'll see the blood actually separate to where the blood will move to the center, and they'll have a yellowish ring outside of that. That tells you that it's CSF fluid. This is types of head injuries, continue to be categorized, whether it's a generalized or a localized, and they can be classified as either minor, moderate, or severe based on their Glasgow Coma Scale. If you look here, head trauma, brain injury, this breaks down the classification for you, and this may be a easier diagram for you to see as far as kind of seeing it broken down. Concussion, this is a diffuse injury. So this is where somebody's had a brief disruption in their level of consciousness. They may have some retrograde amnesia, or they may not, may have a headache. Their symptoms initially are short in duration. It's considered a minor diffuse head injury. They can lose consciousness, but they may not. And they may have this post-concussion syndrome, which is what you see sometimes, where they have headache later, they're sleepy, they're sleeping more, their attention span is shortened, decreased short-term memory, may have some personality changes or changes in intellectual ability. And this is after the initial injury. Diffuse axonal injury is more serious. This is where there's been widespread axonal damage. They're going to have a decreased LAC, increased ICP. This is where you're going to see that abnormal posturing, and they're going to have cerebral edema. About 90% of these cases do end up in a persistent vegetative state, so it is a serious injury. Focal injuries, that is classified down into lacerations, which we've talked about. Just know they may have a lot of bleeding secondary to that because it's vascular. Contusion, this is actually a bruising of the brain tissue, like for instance if they've had a motor vehicle accident and hit their head and the brain is actually bruised. It is a closed head injury. Oh, and just know, with a contusion it can be very serious. So this controcute injuries can occur and with a contusion, and that's basically where the head went forward and hit something to start with, and that was your primary impact. and then the secondary impact is where it went backwards and the brain kind of bounced off of the back of the scalp. And their prognosis for this does depend on how much bleeding is present. So complications of head injuries, epidural hematoma. This is bleeding between the dura and the inner surface of the skull. It is a neurologic emergency. It can either be venous or arterial. Arterial bleeds are fast bleeds. Venous bleeds are slow. They do require rapid surgical intervention to get rid of this hematoma so they don't herniate. Classic signs could be unconsciousness initially, or they could have a brief lucid interval followed by a decrease in their level of consciousness, headache, nausea, vomiting. This here is a good diagram or a good figure to show you the locations of these different types of hematomas. It kind of gives you a better picture of what area they're affecting within the skull. After the lecture, just go back and look at these YouTube videos if you wish to. Basically, it's showing you surgical intervention where they've gone in and removed epidural hematoma. It is graphic, so just know that watching it. Subdural hematoma, this is bleeding between the dura and the arachnoid space. It is usually venous, so they are slower to develop. Some cases may be arterial, but they are typically venous. An acute subdural hematoma manifests within 24 to 48 hours of the injury. The symptoms are related to increased ICP. A lot of these things that we talk about in this chapter are related to ICP clinical manifestations, so know those. Subacute, it occurs later, 2 to 14 days later, and then a chronic subdural hematoma is within weeks or months after what seemed initially as a minor head injury. It is more common in older adults due to the fact that they have brain atrophy, so their subdural space is already larger because their brain has atrophied. So, and often in these cases, it does tend to be a poor outcome or unfortunate outcome because there's often misdiagnosis, and their symptoms may just be focal symptoms, whereas they may not have the typical headache, nausea, vomiting, changes in LOCs. They may just have a deficit in one of their cranial nerves. Here is a video surgical evacuation of a subdural hematoma. It's a very good video footage, but again, it is graphic. Intracerebral hematoma, this is bleeding within the brain tissue, and it's about 16% of head injuries, usually in the frontal temporal lobes. So best diagnostic test to determine bleeds or injuries related to head injuries would be CT scan. You can also get further imaging with MRI, PET scan, some Doppler studies. If you're suspicious of a C-spine injury or you're unsure, always immobilize the spine and check your GCS scale. Emergency management, there's a table in your book that gives you more details of this. You can review that. But airway and stabilize that cervical spine. Make sure to assess your Glasgow Coma Scale, obtain an IV access. A lot of times this is going to be done with MS prior to getting to the trauma bay of the ER. Interprofessional care, the treatment principles are to prevent any kind of secondary injury or complications. Diagnose these people timely. That means getting a CT quickly and surgery quickly if necessary. As far as with concussion and contusion, it's usually observation and management and just doing frequent neuroassessments and maintaining the ICP. Skull fractures, it can either be done managed with conservative treatment and monitoring or surgery if it is a depressed skull fracture. The hematomas, they need to be evacuated either through a full craniotomy or through burr holes. The two videos that you see will be through a craniectomy, where they go in and visualize where the bleeding vessels are and remove the hematoma. Craniectomy is where they actually remove part of the skull and they can leave that off if there's extreme swelling. So assessment, subjective data, we're taking a good history, read through these of importance, especially with your hematoma people. or in general if they're on anticoagulants or any kind of blood thinners at home. Objective data, you're going through and you're looking at your skin, you're checking your LOC, you're checking your Glasgow Coma score. Are they having any kind of changes in their respiratory pattern? What about their bowel and bladder pattern? Are they having any seizures? Make sure to assess your cranial nerves and know your posturing as well as the Cushing's triad. See what your vital signs are doing. And this is frequent assessment. This needs to be done. As far as your diagnostic studies, objective data, seeing what your results of your imaging has been done, and your toxicology screens as well. Goals: maintain cerebral oxygenation and perfusion. You want a good cerebral perfusion pressure. You want to make sure that they're getting that oxygen and glucose to the brain. You're maintaining a normal temperature by administering your antipyretics, controlling their pain and any discomfort or secondary symptoms that they may be having, like nausea or vomiting. That we're keeping things clean, free of infection, using aseptic technique, using sterile technique in the OR, starting nutritional status early, and maintaining as much cognitive, motor, and sensory function as possible. So yes, we are doing range of motion on these patients, but we're not going in there and just quickly raising their legs up and quickly moving and doing range of motion. It's more gentle range of motion. So health promotion, what can we do as nurses? We can educate, wear your helmets, use your seat belts, safety. Nursing management in the acute care phase, some of this is similar to what we've discussed earlier. I'll read through these. One of the biggest things, and I think I did mention this, is, if they're hyperthermic, you want to try to prevent shivering. So when you're trying to bring down that temperature and you're giving Tylenol and it's not working and the patient still is having a fever, and you get an order for a cooling blanket, and all of a sudden their temp is just dropping dramatically and they're shivering so bad that it almost looks like they're seizing, well, that's going to increase their ICP. So you really want to pay attention to that, and you may need to remove that cooling blanket and not cool them down quite so fast. Make sure that you're doing all these measurements as far as avoiding anything that will increase the ICP. Rehab, we're getting the patient ready to get out of the hospital. So it's just addressing all the issues that they have or issues that we anticipate them having to deal with at home, and going through these education aspects here. Evaluations, we're evaluating our interventions. Did they work or did they not? And here's the references. Like I said, if y'all have any questions over lecture part 1, please reach out to me. It's hard to gauge your understanding not being there with you guys, so I definitely am open to y'all reaching out. I just want to make sure you understand the content. Make sure that you're doing practice NCLEX questions in your book and an ATI to help you prepare for this exam. Lecture 2, same thing. If you have any questions regarding this material on Chapter 56, just reach out to me. Thanks.